Fernandez-Miranda. Welcome to Neurosurgery Tales. You
Thank you.
are the world's leading figure in skull-based in pituitary surgery. Your work has significantly redefined the boundaries of endoscopic approach. And you also trained under Dr. Rhoton's and carried that legacy from Spain to Florida, then to Pittsburgh, and now to Stanford. I'd love to start with the moment that probably changed everything for you. Could you share how it was for you, your experience when you chose to leave Spain for Dr. Albert Rhoton's lab at the University of Florida, and how much of that was leap of faith or strategy?
Thank you, Lena. That is a very great question. I do recall the exact moment when that happened. It was in a break during a hands-on course. This is 2003 in Alicante, beautiful coastal city in Spain. And in the break, I approached Evandro de Oliveira. I'm making the story very short. There's a lot of background behind, but the exact moment is that I approached Evandro, who was the invited guest for the course. And I asked him, Evandro, I would love to go to Professor Rhoton's lab to spend 1 month and learn how to prepare anatomical specimens so I can take the technique back to Spain and do it in my hospital, etc. And Evandro, who knew me because I've been following him for years then, he looked at me in the eyes and said, do you want to go with Professor Rhoton for 1 year? He's like, what? 1 year? He said, yes, immediately. But that was a shocking moment. I did not expect or thought I could be chosen to be a Professor Rhoton fellow, but somehow Evandro decided that I should do a fellowship with him. So that was the exact moment when that happened. To get to that moment, a lot of things happened. You know, Evandro knew me. I had been after him. I saw him years before, and I was always impacted by his mastery and how he used Rhoton's anatomy to do amazing surgeries. But that was the exact moment when that happened. Right after that happened, I called my wife, say, hey, babe, this has happened. You know, I have the opportunity to go for a year to Florida to train with Professor Rhoton. Evandro offered me this opportunity. What do you think? He said, great, let's do it. And that's it. That was a defining moment. All thanks to Evandro, and it was definitely a leap of faith. There was no strategy. Again, I was not expecting that. I was definitely going after Evandro because I admire him so much, and I wanted to be next to him to learn from him. But I was not expecting that. It was definitely a leap of faith. Evandro said, you have to go now. It's 1 year, but you have to go next year because Professor Rhoton is going to close his lab. Those were his words. The lab closed 10 years later. Evandro thought the lab was going to close at that point. So he said, you have to go next year. And I still was doing mid-residency. I had to do a lot of logistics to spend my last year of residency with Professor Rhoton. A lot of people thought that was a mistake from family and friends because, you know, to go to Rhoton's lab, you don't get a salary support. So I had to go with my savings. So I decided, with the unique support of my wife, that a small apartment we had in Madrid, we would sell that apartment. And we did sell the apartment. We did sell everything we had to go to work with Professor Rhoton. So it was a huge leap of faith. People were thinking you're making a mistake. When you come back, how you're going to buy something? The housing market is terrible. From the professional side, my mentors in my residency program were saying, you should go 6 months, but no more than that. 6 months is enough. 1 year, you're going to be out of training. You're not doing hands-on in patients, and it's not going to be good for you. But I knew in my heart that was the right thing to do. Is what I wanted to do. I took it as I didn't think it twice. It was clear for me that was the path.
And you've worked across continents, and obviously the era of technology was changing at all this time. That kind of moment probably shaped your kind of sense of limits and what line you can cross in surgery and which one not. Now for you, what is the line you refuse to cross in surgery, even if pushing further sometimes means get it done?
Well, understanding the limits of surgery, it is extremely important. The last thing you want to do is do an operation where a patient gets harmed, because that is very painful for the patient and for the surgeon, especially for the patient, of course. At the same time, I grew and I've grown seeing the amazing operations some of these surgeons do, like Evandro, we mentioned before. He was doing so many cases that were thought to be inoperable. And many other examples there are. I train in Pittsburgh later with Pittsburgh team, and for example, my friend Paul Garner doing amazing cases that many others would not tackle, and these surgeons would because they saw the benefit of doing that. So as long as there is a benefit for the patient, as long as the reward is there, I think the risks are worthy. But you need to understand the limitations for sure. There are cases, it takes years of experience to get to the point to understand when a case should be done and when not, when the benefit is potentially there or not. And there are cases these days that, of course, I say no. There are patients that are with, let's say, multiple recurrent chordoma, and I just think that another operation might not help them. I can maybe do it, but if I cannot make a huge difference, the risk is not worth it. So there are cases where I say still no. At the same time, there are others I say yes, where many others maybe said no, or they thought it is not worthy. But every surgeon needs to have its own balance. Find the balance between what the risks that the patient will face versus the benefit that they can obtain. And if the balancing benefit of patient's benefit, I will go for that.
And this also brings me to ask the next question. How do you define complete resection when functional risk is obviously significant?
Well, it depends again in the pathology. I can maybe answer with examples to that question. Let's say things that I do very often are pituitary adenomas that invade the cavernous sinus. For the most part, for functional pituitary adenomas, patients that have acromegaly, Cushing's disease, prolactinomas, I do believe that achieving complete resection is extremely important in the first operation, if possible, at the expense of some potential risks. Specifically, the main risk is double vision, diplopia from cranial palsy. But we know that the majority of these patients, even though they might have double vision post-op, they recover. Our data shows that about 10% of the patients might get double vision post-op, which means 90% don't. But the 10% that do, the vast majority of them, 90% plus, do get better in 3 to 6 months. So to me, that is a risk worth taking. And for the patients is too. The patients are happy with the outcome when you look at the outcome 3 to 6 months. I always tell my patients, you cannot look at the outcome of an operation 2 weeks after the operation. You're not doing an operation because of how you're going to be in 2 weeks. You're doing an operation for how you're going to be in 6 months and 6 years from now and 20 years from now. That is a long-term investment, not a short-term investment. Other example is, for example, that is controversial, is pediatric canopharyngiomas, a pathology and population that is very dear to my heart because I've seen so many kids with canopharyngiomas that have been mistreated. Or, the surgeons did the best they could, but they did partial resections, they do go for radiation, another operation, and it's a life of misery for the children. If you can do an operation at first that is curative, and in canopharyngiomas, this is often possible, not always, but very often, we can cure these tumors at the expense of pituitary dysfunction. That is the price to pay, unfortunately. But these patients can be placed on hormonal replacement and have a very normal life, grow normally, develop normally with no tumor. That is definitely a price worth paying, in my opinion. And patients and families agree. You can cure the canopharyngoma, even though those that go into the hypothalamic region. There is a lot of dogma, for example, about not removing tumors from the hypothalamus because of the risk of cognitive deficits, hypothalamic obesity, the hypothalamic syndrome, basically. That dogma comes from the time where endonasal approaches were not well developed. Mostly done through a craniotomy approach. We advanced endonasal techniques. We've seen how we can really remove these canophoryniomas from the hypothalamic region entirely. Our patients do very well without hypothalamic syndrome. And, that is an example of how a complete resection is worthy in spite of the deficit of, for example, pituitary dysfunction in these patients.
And you also presented at numerous conferences the reconstruction and how to reduce the CSF leak and this kind of reconstruction surgery, post-surgery reconstruction. Have you noticed a single change over the last years that probably mostly reduce your CSF leak rate? And if yes, which one?
I don't think there are any changes we've introduced in the last 5 years because I've been very methodically about reconstruction. But I do take reconstruction very seriously, and for high flow leaks, two things I would say. One, for high flow leaks and for low flow leaks. For high flow leaks, I almost routinely use fascial grafting. I'm trying to move away a bit from it and use some alloderm or other type of patching, but I like fascial very much, even though it requires an incision in the patient. It's excellent material. And the lumbar drain on top of course, the flap. So I use lumbar drain very often in these high flow leaks. And I've been doing for many years. We did a study in Pittsburgh many years ago where we saw that it makes a difference. It reduces the risk of leakage 2, 3, or even 4 times. For low flow leaks, something that I do that other surgeons I know might not do that often is when we have a low flow leak, let's say, for example, a pituitary adenoma, there is some whipping of the CSF. Many of my colleagues, they would use fat grafting or mucosal grafting, which is good, but sometimes fails. There is a failure rate that can be 3-4% approximately. In some of those cases, we often do flaps, even especially the patient is obese or has a functional tumor. We might do a flap, and we have a low threshold for that because our rhinology team is very good, and they believe that it doesn't increase patients' morbidity, maybe in the short term. But not in the mid or the long term. The morbidity is not there. Patients recover very well from the flap harvesting. Now, other techniques that we used that I think are very important, especially when we're talking about multiple recurrent CSF leaks, recalcitrant CSF leaks, which are real nightmare. Patients that have one leak after the other. It's very important for surgeons to learn how to rely on other flaps. Especially, I become very enthusiastic about the temporoparietal fascia flap based on this. It's not easy to harvest, but it's not so difficult actually. And it provides a lot of robust vascularized tissue for reconstruction. We are actually putting a paper together on this. We put a paper on the technique, but now we're putting a paper on outcomes. We use it 8 times in 7 years. So this is maybe once a year. So it's rare. But the time you use it is a life-saving procedure. These are patients that, let's say, a clival chordoma that had multiple leaks. We cannot repair it. The patients have meningitis, vasculitis, they develop multiple issues, and the lasting resort is the TP flap, and has saved the life of these patients very often. Also, I would say another very important adjunct is free flap. It's another reconstruction technique that we need to have available. For example, I've learned over the years when we do these very large anterior skull base resections. Let's imagine a giant extensor neuroblastoma that goes from the sella to the frontal sinus. It is a huge defect. At the beginning, I tried to do this with pericardial flap. But pericardial flap is a thin layer, only 2 layers of the scalp, not very richly vascularized. So they can fail. The failure rate of a pericardial flap in that setting is quite high, I think. So in cases like that, we've relied early on, upfront, on a free flap. We bring the reconstructive team and they do a free-form flap for these very large skull base defects. And I think that's a better strategy than trying a pericardial flap and then having to do a free flap later. I'm talking about, extraordinarily large defects, not the usual case, of course, is the rare case that, is giant. A handful of those over the last years.
And speaking of evolving techniques, every field has trends that sometimes swing too far. Which approach do you think is currently overused? And if there is such an approach, what narrow indication does it still belong to?
Well, I think there is, personally, I think there is a lot of hype on the transorbital approach. It has its merits to me. And the endonasal approach had a hype also. For example, if we focus on the endonasal approach, things that I don't do now that I used to do in the past, anterior skull base meningiomas like olfactory groove especially, and planomeningiomas, I used to do them endonasally. We did many of them in Pittsburgh. My colleagues there still do them that way for the most part, I believe. But I've changed to some extent, and I do most of them through an open approach because I think it's safer for the patient. The risk of CSF leakage is lower. It is also easier. It has less limitations. So I think probably anterior scopus meningiomas endonasal approach for them is overindicated. And I think the traditional scopus approach is better. For the transorbital, again, there is a lot of hype, I think. If we compare it to the endonasal, the endonasal approach has the powerful aspect of the endonasal approach is the approach itself. It provides a ventral corridor to the skull base that you cannot get with any other approach. You come from a lateral approach, you have cranial nerves, vessels in your way. It doesn't give you the same view. It's unilateral, etc. Endonasal has tremendous power. Transorbital is not the same. You have all the open approaches, all the endonasal approaches that can reach and do the same. There are a few exceptions. You have a tumor in the anteroposterior axis. Maybe a transorbital approach might have some benefit. And I think that is worth exploring. Tumors that are, for example, going along the tent, in the back of the cavernous sinus, Meckel's cave, it's possible that a transorbital approach offers some benefit there in comparison with the other approaches. Because endonasal is medial, this is paramedian. Because the lateral approach, you have to work underneath the temporal lobe. There are some potential benefits there, but I do think they are narrow. I do not like seeing excessive use of transorbital approaches, especially when it's to the detriment of the quality of the resection. I've even reviewed papers for journals where they show the post-op and there is residual tumor and they do a poorer job on the tumor resection just because it's less invasive. So if it's less effective, if minimally invasive is going to mean minimally effective, then it's not worth it. It has to be equally or more effective than the standard approaches, right?
Yeah, it makes sense. You also talk a lot about training the next generation. It seems like the simulations is the next frontier for us, for new generation. And you also co-author an oral presentation that will be presented at the CNS at 2025, which is realistic visualization of neurosurgical simulation and education. Beyond anatomy, what other, if there is any, stressor that must a simulation include to be clinically relevant?
That presentation, it is the work of one of my fellows in the lab, Tatsuo, a fellow from Japan doing University of Tokyo doing amazing work. He basically created the whole skull base and brain with Maya software with all the details. The beauty of that is that we match it with our anatomical dissection. So he incorporated in that model things like the paracellular ligaments, the arteries of the cavernous sinus, things that are not, you don't find in Atlas of Anatomy, neuroanatomy relevant. And that transfer into a VR model is an amazing experience. I know you have experience before using one of these digital models in VR where you can actually walk through the foramen magnum or, put your hand through the hypoglossal canal. You can even swim or navigate through the cavernous sinus yourself. It's an amazing experience because you can make it as big as you want and you are fully immersed into it. And I love that. But the problem is that these systems are not patient specific. And when you use imaging, the quality, when you make it huge, it is not there. We are still struggling with the limitations of the spatial limitations of imaging, which is 1 or 2 millimeters. We need higher resolution for what we do because we need to look at the details of, the microvasculature, the cranial nerves, things that the imaging doesn't show you yet. And I believe, maybe 70 MRIs in the future. There is now, we're using this photon CT scan. You have 0.2 millimeter resolution. These are amazing. I think we can get better simulation reconstructions for planning and for simulation. Still, I do feel strongly on the use of anatomical specimens for training and simulation. I know they are limited. I know they are expensive, but they are invaluable. There is no substitute, in my opinion, to real anatomical dissection on specimens. And the same for simulation. I'm sure you're familiar with the Abud model that they created where they inject the vessels and they use a pump. You can perfuse the vessels and you can simulate a scenario where there is bleeding. If you want to train an aneurysm surgery, you can simulate a vessel bleeding, or you can create an aneurysm and make it bleed and you have to clip it. We've used it in my lab for endonasal approaches to simulate what we fear the most, which is a carotid-injury, which is a terrible event to happen in the operating room. Mm-hmm. but you can actually train, and it's been useful for me. And we emphasize the training of with this live simulation. You can simulate how to repair a carotid injury. Even your heart rate increases when that happens. Even you have an emotional response because you see the bleeding
Yeah.
coming at, and you have to go and control it. And you can use, and it's the perfect scenario because then I can play with clips. I can try to wrap it and a wrapping technique and reconstruction technique. I can do things that in the OR hopefully you don't have to experience, but if you do, at least you have some training to deal with such a delicate situation.
Do you think it will be possible to create a model that records the surgeon's experience, like like heart rate, like his emotions, and then another model that is specifically created based on the patient anatomy? Like you have tomorrow surgery, and you can go in and prepare fully for this specific patient.
Yes, I think that's coming, and there are already models out there with 3D printing, right? They are very promising and interesting. Again, the problem is the same as we mentioned before, is the spatial resolution, the lack of detail, of the detail that really matters the most. Because, macro, let's call it macro things, macro anatomy, we can visualize well. What is the carotid? What is the MCA? What is the optic nerve? What is the tumor in relation to the, clinoid, etc. But at the end, you want to know, okay, what is the superior hypophyseal artery? Do you see that? Where are the perforating branches from the carotid? Are they encased? Are they not? What is the sixth nerve? What is the fourth nerve? All those details that we cannot see in imaging. That's what we're missing. So I do think that those models are very useful, especially at the trainee level. I think for an expert surgeon or a surgeon with experience, we are a long way to go because we need a lot of details that imaging is not yet providing. Therefore, you cannot simulate them well.
Our habits obviously influence our work in the OR, like our habits outside the OR. Is there a habit that most improve your intraoperative judgment? And if yes, how do you practice it?
Well, in the operating room, something that is critically important for me, I tell my trainees, my fellows, that precision in the operating room is not about millimeters of precision. It's about milliseconds of precision, meaning it's about being concentrated. It's the ability to stay concentrated. It's when you get distracted when you make mistakes. It's when you suddenly lose your concentration, when you tear a vessel or you pull too much on a nerve and you make those mistakes. The ability to stay concentrated during surgery, it is key and it's not easy when you're doing operations. Let's say you've been, especially when you are 3-4 hours into an operation and you've been working the microscope or with the endoscope, beyond that time, it is difficult to keep the concentration. You need to be very well trained on the ability to stay concentrated. And I think that's a key factor. We focus so much on the technical skill, which is important, but the technical skill is about the concentration you are having during the procedure. So I do believe that, I'm not sure how you train that out of the operating room, but I think it probably has to do with your personality. You definitely need to be a patient person. You can practice meditation, which I do, as a way to, I do, for example, especially for complex cases. For routine cases, you don't need to because you already have been there many times. But for complex cases, where you think you're going to face something that is unusual, you don't have much experience for, or is an extremely complex case, we always rehearse the operation in your mind. You need to see every step. And there have been cases where if I don't see every single step of the operation, I just cannot really sleep well. I have to really understand everything that's going to go on the operation and what's going to happen here if this goes this way, what's going to happen there, and have all the options, plan B, C, D, line up. I need to sort of predict in my mind what is going to happen and how things are going to go. Maybe things will not go that way, but at least I need to have the comfort. I understand what the strategy is. And I do think that a lot of the successful surgery is on the strategy, right?
Mm-hmm.
At the end, expertise very much comes with being able to perform a good strategy for a particular case. You don't pay enough attention to the plan of action, what steps you're going to take. That's a recipe for disaster. You need to be well prepared, a well thought out plan.
And the next question is a specific question that I wanted specifically to ask you, the master. When a case is technically perfect, but the patient's life doesn't meaningfully improve, What do you audit first? Selection, timing, expectation, maybe something else?
Well, if the patient does not benefit from the operation, then probably there's a problem with the indication.
Yeah.
Now, we need to make a differentiation because sometimes we do preventive surgery. Let's say you have a tumor that you meningioma, adenoma, whatever, that you are operating because the tumor has some growth. I think that's very important. You always want to document growth. If you operate the first meningioma that surpasses in your clinic, then that's probably not right. You want to see a meningioma that is growing, and the patient has an age that is not old. Let's say he has 20, 30 years ahead, and you do a preventive operation. So that patient is not going to be better after the operation. It's just you are preventing something from happening. So that's one scenario. Operating on a patient that doesn't have not even that benefit of prevention, then probably it's a problem of the indication. Watch and wait is often a very good strategy for many cases. Even sometimes I do watch many cases, patients with even large tumors, if they are not symptomatic and I think the operation is going to cause more damage than benefit, and it's a slow growing tumor, I prefer to watch. To me, very distressful. Doing an operation is not helping a patient. So I avoid that at all costs.
And you're also deeply involved in teaching the next generation. What do you hope your fellows surpass you in?
I hope they surpass me in everything. In the technical aspect, in the academic aspect. At the same time, I always stress them that there are no shortcuts. In surgery or in your career, if you try to get a shortcut, it's typically not going to work well. Fellows are sometimes, when they graduate, they are very anxious to, develop their career and tackle the big cases. You need to be careful. You need to be patient. You need to build a large, wide base. As I always tries to explain them, that's why I think the work in the laboratory is so important. People tell me that's a mistake, you shouldn't do it. But for me, it was building like a very wide base, and then you can raise a very tall building. You have a very big base. But that base is first. If you have a narrow base and you try to make a tall building, as you know, it's gonna crumble, right? So I want the fellows to, of course, surpass me and do better than I am, that I'm doing today, have better outcomes, tackle more difficult cases that we cannot today. But I wanted to do so at the right pace, not trying to do that too early because it's probably not going to work well.
And lastly, with all your wonderful journey, what part of you has stayed exactly the same since starting residency, and what part do you think is unrecognizable now?
That is an interesting question. I think I've stayed the same in many aspects. It's critically important that we always remember where we come from, our journey. Also, it's important that we know who we are and what we do, the value we provide, but also where you come from. The things that have changed me the most is complications. Of course, complications is what changed you the most. Let's call it surgical scars. Those are the one that reshaped you as a surgeon, and you carry with you for all your life. And that is something that changed. The innocence, the naiveness when you are a young surgeon, you lose all that as you grow up and you are in 1,000 battles in the operating room. You lose that. But at the same time, you gain something much more valuable, which is you become much more wise. You know how to handle difficult situations. You know how to avoid difficult situations and how to avoid mistakes made in the past. I like to think that the passion for what I do has remained the same. I still enjoy doing operations very much. I think it's a privilege what we do. And I still enjoy teaching my fellows and my residents. I still enjoy the work in the laboratory as I did in my first days. And I hope that doesn't never change.
Thank you so much. Thank you so much for this discussion, this conversation, and your openness.